Hi everyone, Dr. Kent Hungerford here. Today we're just going to be talking quickly on hammer-toe deformities. So hammer-toes, claw toes, curly toes, mallet toes, we've got quite a number of different sort of ways that we describe it or we name it. But they're all names for the toes that are bending in different directions, different ways, and typically related to that instability of the forefoot intrinsic muscles. Typically we do see that progressive foot deformity is related to the plantar plates, and really having a bit of an idea around that and how that all works in is really important as to how we treat these types of concerns. We classify hammer-toes in different ways. Those pediatric ones are likely reducible, can be triplanar. But typically they're just that really curly toe, whether it's off to the side in different directions, and typically resolve over time. When we start talking about flexible, these are the sort of, earlier age, potentially chronic, but are able to be reduced completely. Typically these type of toes are just in the single plane, being the sagittal plane, and they're typically just that curled toe as we often do see. When we start talking about semi-rigid hammer-toe deformity, we start to see that they're maybe potentially only partially correctable. There's mild to moderate arthritis, but we're still able to get it straight, or up to 80% of the way straight. Otherwise, and there's nothing that's preventing that full correction as such. When we start talking about a rigid hammer-toe deformity, the toe's very much unable to be moved, or maybe only providing a 20% reduction of deformity when we are moving it. There may be that triplanar deformity, so not only that sagittal, but it may also be off to the side. It may be subluxed or dislocated off the metatarsophalangeal joint or off the interphalangeal joints as well. So that's something just to be aware of around the classification side. To put that into a picture type form, because again, if you're like me, it's really about making sure that we've got those pictures to back it up. Our pediatric toes just here, and we can see that these toes may respond quite well to that nappy change type of, correcting that massage when we change the nappy. That's the prompt for mum and dad to go, okay, let's start massaging that out. Similar here with the flexible, different options available there, which we'll go through in a moment. But these toes are much more likely, whether they're in adolescence or early age adults, that they're going to be corrected. But when I say early age adults, I've often seen even up into their 90s correctable flexible hammer-toe deformity, and that really opens a few different options as far as treatment. We start looking semi-rigid, and in this case, that's a proximal interphalangeal joint that may have subluxed slightly, not allowing that patient to have an appropriate correction through reduction. And then we start seeing our rigid deformity. These are pretty much dislocated off. That looks to be the head of the proximal phalanx with the base underneath here. And so, we start going, okay, there's concerns there that maybe are unable to be addressed through without a bony procedure. We've got multiple deformities in different planes as well, so it definitely does add that high risk. Now these patients are typically our later stage arthritis, potentially rheumatoid, with dislocations that are, or subluxations that are apparent. To get a greater idea of imaging and of what they look like, we need imaging. Again, x-rays are sort of my go-to initially to have a bit of a look. We can have a bit of a look at the ultrasound to check that plantar plate. And when we start talking about ultrasound, I suppose it's really important to sort of mention here that we want to rule out different pathology when we're doing so. In different radiology clinics that I refer to, I know that if I say plantar plate, they won't necessarily check for neuroma, or vice versa. When a lot of the time, I do want to exclude or include a neuroma when I'm looking at a plantar plate, and again, vice versa, because that's going to change my management quite significantly. And I need to get a better understanding of, okay, if there's attenuation or a tear of the plantar plate in conjunction with a neuroma, is it the neuroma that's caused that, and whether I treat the neuroma rather than the plantar plate. And of course, this will come down to symptomology as well. MRI can be helpful in this regard, and the research is sort of there as to where the MRI does have a place. And typically, in significant deformity, it can be helpful to exclude some concerns, or when you're having a bit of trouble between that plantar plate and neuroma and want a little bit more guidance around there. Remember, with your MRIs, a typical cross section is 2 to 3 millimeters. You can lower that down to 1.5 millimeters or so, rather than a 3 millimeter, to get a really much better idea of how large these lesions may be. Because 3 millimeters can be quite a large cross section where you're potentially missing the whole nerve or only getting one frame of that nerve. And so really important that we have a bit of an understanding of, okay, where our imaging is good, but also how can we get the best option or best outcome from that imaging when we look at it. If you're unsure about these sort of things, have a bit of a chat with your local radiologist, who are more than happy to have a bit more of an in-depth chat about what works for them. Now, when it comes to conservative management around our hammertoe deformities, obviously orthoses is a really big part that comes into our footwear, being a wider and deeper toe box as well. Give those as much room as possible. Depending on what's happening, you may need to look at a metatarsal dome, or depending on that metatarsal parabola and that relative metatarsal length, whether it's plantar flexed, you may need to have like a second metatarsophalangeal drop or cutout to allow that deformity to coexist in that area. Remember, we've got our splinting, our taping, our props, the wile strap, which helps to pull that toe down. All these type of things are available as well. Exercise and physiotherapy, really looking at that intrinsic strengthening, and again having a look at that broader biomechanical correction, so that we can make sure that everyone's going to be not only to the forefoot but the rear foot, and how that's contributing to forefoot pathology. The reassurance is a big part. Try to get that diagnosis, give them that very clear plan and say, okay, if this doesn't work, this is what we're going to look at. If that doesn't work, then let's look at this. Right through as much as you can, so that that patient's reassured that, one, what their problem is, how to treat it, but also most importantly, what's the next step if this fails. Patients like to hear everything, even if they're not going to go all the way down that track of management. And I know myself, I'll go through all that conservative. What hasn't been exhausted, I'll talk about that. And then I'll just say, just so you're aware, if this doesn't happen, there is a surgical approach that's available, or there is an injection therapy that's available, or there is this other treatment that is available. And then, talking about the pros and cons to that as far as I know. I suppose having a good understanding of when to refer is really critical, and the patient education around that is really important as well. And so give your patient as much education so that they can make that informed decision as to whether they want to look at a surgical option at this stage. And that might be quite an easy conversation for some patients, and some patients may be unsure. I suppose when there's a flexible deformity that's in an adolescent or younger adult, it's a really easy way to say, we can fix this there. It may cause concerns later on, and that prophylactic type of surgery can be a good option once we fail the conservative options. Particularly think about this for patients that are at risk with diabetes, for instance, or that maybe they're not going to have as good an outcome due to their potential medical conditions later in life. And so where we can undertake these prophylactic procedures, it can be a good option to look at. Now, if they are a pediatric, a young child, weigh up the impact that it's having on their health, mental health as well. Coming to a doctor can be quite stressful. Having a local anaesthetic can be quite stressful. And where that patient or that child is of a sound age, having a bit of a chat to them as well. And although that parent's signing the consent, I always make sure that the child, even if they're quite younger, understands what I'm doing where they can, and what we're actually going to be doing and why. I think that really brings them on board. The parents are more relaxed because of that, because it's given them a little bit of an extra time to make sure that everyone's comfortable in that position. Always trial the conservative. If there's no resolution, you can discuss surgery, but there's quite a lot of different options, particularly in those younger patients, where, you know, that massaging out is quite critical and can quite help a lot. You know, we've all seen those infants, whether they're toddlers, babies, come through, and mum and dad are just looking for reassurance because their child has a very flat foot and curly toes. I've seen it quite a lot, and a lot of the time it's just, you know, nappy change massage, reassurance, and yeah, no problems. Let's check in again in 6 to 12 months and make sure everything's proceeding as we would like. Once they get into an age where they, you know, may tolerate different things like local anesthetics and the needles, then that's when we can start to talk about some of those different procedures potentially. Again, if you're unsure, ask for an opinion or refer for one. You know, we're not saying that we're going to do surgery. It's all about just giving as much information as possible. When we talk about the surgical management, there's obviously a few different ways to do that, whether they're minimally invasive or open, and I'd like to go through a few of those for you today as well. When we talk about minimally invasive procedures, we can start with the flexiotomy, for instance, percutaneous, basically undertaken with an 18 gauge needle or a very fine beaver blade as well. Could be an option that we do, and I sort of move between these depending on what the patient's needs are and sort of how much of a blade I need to use. A lot of the time for my tenotomies, it's just an 18 gauge needle through the bottom of the toe. I release the tendon and a little bit of the capsule, bring that toe into a nice straight position, and then undertake some taping as well. So not only do I do this normal ribbon type taping, which we'd know quite well from plantar plate tears, but also just having like a stereo strip or another piece of tape dorsiflexing from that distal phalanx so that we can bring that toe back into that straight corrected position. You know, there's no fixation here. It's all just the taping or a brace even. The wile strap is another option that I use. And, you know, other options are, you know, using these type of hammer fix implants as well. And this one I'm typically undertaking through a minimal incision, just a 1 centimeter transverse incision, you know, across the proximal interphalangeal joint, removing that head of the proximal phalanx, the base of the middle phalanx, and then this implant goes in. And they're typically given really good outcomes that, you know, very often don't need further surgery and allow that implant to sit in a nice place. When we start looking into our open procedures, we start talking about, you know, whether we're needing more access for more correction, whether we're also doing plantar plate repairs at the same time, whether we're doing metatarsal osteotomy, so the wile osteotomy. And you can see here we've shortened that second metatarsal and put a screw in at the same time as doing the arthrodesis of that proximal interphalangeal joint with another one of our implants that can go into that area. There may also be the need to do an arthroplasty where we remove that metatarsal head. These are patients that have got severe rheumatoid arthritis potentially, and you know, these are very late stage disease and potentially have had other procedures beforehand that have been unsuccessful. When we start talking open, you know, depending on how many toes, there's going to be a bit of swelling, you know, potentially poorer ability to ambulate initially. And so having that really good discussion with your patients as much as you can is a really good idea. But I think, you know, these x-rays, they give you a bit of an idea of what we're looking at, some of the implants we're looking at, and how we're wanting to correct those deformities as well. If you would like any further information, please feel free to get in touch with me at South Coast Foot Surgery. Send us an email. There's more information on our website regarding some of those recovery times. But, you know, typically for those tenotomies, you're releasing that flexor tendon, you're in the dressing for 3 days and then back into joggers. For our more invasive procedures where we're doing bone work, it may be 2 weeks before you're back into your jogger. But again, this depends if you're having a bunion corrected at the same time. It really depends, obviously, on each patient and their presentation. But reach out. More than happy to have a bit of a look at some imaging and potentially help you recommend the best course for your patients as well. Thanks.